Greetings and welcome to this video on Fluoroquinolones masterclass. In this video, we'll discuss about Ciprofloxacin, Levofloxacin, and Moxifloxacin in detail and its use cases, the contraindications, the adverse effects, the interactions, and everything in detail. If you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. Fluoroquinolones, overall, the big picture it is a very good broad spectrum coverage drug, excellent oral bioavailability. So when you switch from IV to oral switch is very very easy, and it has a very deep tissue penetration. But the bad things are that it is high toxicity burden and significant collateral damage to other organs, and now considered as reserve antibiotics if other drugs are not used. So in this video, we'll discuss in detail about ciprofloxacin, levofloxacin, and moxifloxacin. Mechanism is it is a DNA gyrase inhibitor, which is topoisomerase 2. So also inhibits topoisomerase 4. So blocks the DNA replication and transcription. So resulting in bacteriostatic action and not the cidal action. So it is a concentration dependent killing mechanism. So more the concentration of drug, more is the killing. It is not like beta lactams where the time more than minimum inhibitory concentration is the type of killing. It now here it is concentration dependent killing. So the most important thing is not the time. No, it is the area under the curve above the minimum inhibitory concentration. That is what is required for mechanism of action of this drug. So there are very wide range of contraindications for fluoroquinolone drugs, and absolute contraindications are there. For example, myasthenia gravis. Even macrolides are contraindicated in cases of myasthenia, but these fluoroquinolones are highly toxic for myasthenia gravis patients and exacerbates muscle weaknesses. There's history of tendon disorders, like when you use a fluoroquinolone drug, always ask for tendon disorders like anterior cruciate ligament rupture in the past, knee joint tendon, elbow tendon ligament tear, because it has a lot a high incidence of tendon rupture because of weakening of tendon. So also there is a lot of cases reported as Achilles tendon rupture after usage of fluoroquinolone drugs. It mainly inhibits a lot of collagen and connective tissue uh, areas, so that it creates pathology in the aortic area, can lead to aneurysm or dissection. Neurologically, it can cause seizures and peripheral neuropathy in selected cases. So, fluoroquinolones mask TB and promote resistance. So, use only if TB is ruled out. Always use fluoroquinolones only if TB is used, especially moxifloxacin. Use it only after TB is ruled out. Because moxifloxacin is one of the drug used for treatment of tuberculosis in MDR drug regimen or secondary drug regimen. So in place of pregnancy and children, risk benefit analysis is required. So cartilage concerns in animal models, cartilage dysfunction is there in fetus. So try to avoid it in pregnant females or in children. This is the most important side effect, QTC prolongation. It is significant contraindication for Levo and moxifloxacin. The risk hierarchy is, whenever you have an elderly patient coming with loose dose, take an ECG. If there is QT prolongation, then go for full prolonged group of drugs for acute gastroenteritis. It is lowest with ciprofloxacin, but still there is a risk of QT prolongation. Intermediate risk with levofloxacin and highest risk with moxifloxacin. So avoid in baseline prolonged QT in cases of hypokalemia, hypomagnesemia, which is very very common in acute gastroenteritis patients, and concurrent QT prolongation drugs that is amiodarone, ondansetron, never use fluoroquinolones with these group of drugs. So because of this major adverse effect of this drug, this fluoroquinolone group is now gone lot of out of favor for major physicians in the major part of the country. So it is not currently being used as the first line agent because of this major adverse effect. There is a class-wide drug-drug interactions is there because of the chelation effect. Oral absorption drops significantly with polyvalent cations. So main culprits are magnesium, aluminum antacid, sucralfate, iron supplements, and zinc. So for a patient with vomiting, if you want to give him sucralfate for gastritis and want to treat AG also, then there's no point in giving a ciprofloxacin and a sucralfate. Again, the same goes with magnesium and aluminum silicates. Don't deal with iron supplements or zinc. So separate dosing is required. Administer fluoroquinolones at least 2 to 4 hours apart from these agents. That is very important. Ciprofloxacin has another extra side effects compared to the classified side effects. It mainly inhibits cytochrome P1A2, and it dangerously increases the levels of theophylline, especially theophylline. So never give a fluoroquinolone drug for acute respiratory infection, and also prescribe a theophylline group drug. Thus, it can lead to seizure risk. Again, neuropsychiatric drugs, antipsychotics such as clozapine, olanzapine, there is a risk of antipsychotic toxicity, and again, duloxetine, there is increased exposure. So again, these adverse effects have made it not in favor. Always check interaction before prescribing ciprofloxacin. Always check interaction checker. A lot of interaction checker are available in the online websites or in the Medscape that you can use before prescribing a ciprofloxacin drug to anybody. Moxifloxacin and levofloxacin have a cleaner profile unlike ciprofloxacin, very fewer drug-drug interactions. There's no significant cytochrome B inhibition. So it is comparatively cleaner profile in case of drug-drug interaction. Still, the adverse effects still remain the same. In fact, more than ciprofloxacin, levofloxacin, moxifloxacin prolong the QT interval. Overall side effect risk comparison. So overall safest is levofloxacin with lowest neuropsychiatric and lowest clostridium difficile risk and intermediate QT prolongation risk. The first overall is moxifloxacin with the highest neuropsychiatric risk, highest QT prolongation, highest dysglycemia, and intermediate to high risk clostridium difficile infection. So gatifloxacin, one of the fluoroquinolone drug, orally it was available in the previous days. Now completely banned for oral usages and now only available for topical usage in case of ophthalmic preparations because of its highest dysglycemia risk. Patient can either present with hypoglycemia or hyperglycemia. The drug interactions are very rampant, and so it's gone out of favor. Gatifloxacin. Neurological toxicity, it can cause confusion, agitated delirium that is called as antibiomania. So when you give a cardiac drug and a patient having this agitation or delirium, suspect antibiomania. Tremors, seizure, close the seizure threshold. So when in a patient with seizure disorders or in patient with Parkinson's, already the patient in septic shock with confusion, agitation, delirium, don't prescribe a fluoroquinolone drug. Moxifloxacin has the highest delirium risk with levofloxacin has the lowest severe CNS toxicity profile. QT prolongation arrhythmia implicated drugs are especially the levofloxacin, moxifloxacin. So these are the risk multipliers. In the case of structural heart disease with MSMR, with ventricular septal defect and other polypharmacy drugs like antiarrhythmic, antipsychotics and macrolide group of drugs, if prescribes, can multiply the risk of QT prolongation and arrhythmia, can lead to even ventricular tachycardia. So hypokalemia and hypomagnesemia, if present, don't avoid usage of fluoroquinolone group of drugs. Clostridium difficile infection is highest with ciprofloxacin, whereas it's lowest with levofloxacin. But still, there is risk of Clostridium difficile infection due to colonic floral disruption. So try to avoid this group of drugs for this adverse effect also. There is other side effects such as dysglycemia. It can cause unpredictable hypo or hypoglycemia. It is cannot be predicted. So highest with moxifloxacin. In fact, highest with gatifloxacin, then with moxifloxacin, then with ciprofloxacin, then with levofloxacin. Lowest with levofloxacin. Tendon rupture is quoted as a black box warning. Risk increases if age is more than 60 and concurrent steroid use. In case of hypersensitivity, anaphylaxis, serum sickness, Steven Johnson syndrome, it can be severe and rare. So why fluoroquinolones should be avoided? So now rising resistance of E. coli, more than 25% of strains are resistant. The strong selection for MDR organisms are present. No benefit for double coverage for Pseudomonas. All these things makes it unfavorable. And also the toxicity risk, delirium, persistent neurological and connective tissue injury, penicillin allergy. In that cases, use cephalosporin more than ciprofloxacin or fluoroquinolones. And the FDA black box warning that all these cases made it unfavorable in current era. Monoclonals and Pseudomonas, the people consider giving a beta-lactam drug along with a fluoroquinolone to cover for Pseudomonas, which adds little or to no benefit. So double coverage that was used in the past is now a myth. So better option is you can go for aminoglycosides, which has value for double coverage. Fluoroquinolone does not add any value due to resistant mechanisms of Pseudomonas to fluoroquinolones. Spectrum, gram-positive, it has coverage against few organisms like Streptococcus pneumoniae, MSSA, and Enterococcus, that too only Enterococcus faecalis. So MSSA is active against levofloxacin, moxifloxacin active against MSSA. Again, the drug of choice is ciprofloxacin. Streptococcus pneumonia for respiratory quinolones such as moxifloxacin, levofloxacin can be given. These are respiratory fluoroquinolones, covers high-level penicillin-resistant strains also. And just remember, Enterococcus faecium is intrinsically resistant to fluoroquinolone group of drugs. In case of gram-negative coverage, it can cover against Pseudomonas, Ciprofloxacin, Levofloxacin, but not Moxifloxacin. It's generally good activity, but resistance is rising. Other gram-negatives such as Stenotropomonas, Maltophilia, Levofloxacin is active. For Moxifloxacin, it means Providentia, Protease, and Serratia, the PPS group that is present in urine. Moxifloxacin cannot be used. So prefer Moxifloxacin in case of respiratory symptoms and Ciprofloxacin or Levofloxacin in case of urinary symptoms. Considering the other adverse side effects of moxifloxacin, try to avoid that also. It has highest QT prolongation risk. So anaerobes and respiratory pathogens. So only moxifloxacin has a reliable anaerobic coverage. So warning, resistance is increasing against Bacterius fragilis. Respiratory can cover against H. influenza and Moraxella. Atypical such as Mycoplasma, Chlamydia, Legionella can also be covered. Levofloxacin or moxifloxacin more than ciprofloxacin for atypical organisms. Again, there are better drugs because of the adverse effects and side effects of these group of drugs. Nowadays, other group of drugs are preferred compared to fluoroquinolones. When to use a fluoroquinolone? That is what is the most important thing that you must need to understand. So, only if no better option exists. Case of step-down therapy for MCP diseases, Enterobacter cloaca, Providentia, Proteus, Serratia, ESBL organisms, if they are susceptible, you can go for a fluoroquinolone drug. Prerequisites only use if beta-lactams are contraindicated or there is anaphylaxis for beta-lactams. And contramoxazole is not a viable option and oral option strictly required for MDR organism. Only if these three criteria are fulfilled and when it is an AMS producer ISPL organism, step-down therapy, only in these cases use a fluoroquinolone drug in the current era. Otherwise, there are better options available. So, these beta-lactam are contraindicated and cotrimoxazole is not viable. Oral option is strictly required. Only in these cases, use a fluoroquinolone drug. This is the most important takeaway slide of this talk. So, treatable infections can use for UTI infection, urosepsis, ciprofloxacin, levofloxacin, but not moxifloxacin. Respiratory, again, say levo and moxifloxacin can be used, also called the respiratory fluoroquinolones. Intra-abdominal, it can all Cipro or levofloxacin with metronidazole. Moxi monotherapy is risky due to resistance. Skin and soft tissue infections use with caution. For meningitis is not the first line, there is limited emissions. So, not used for skin and soft tissue. In intra-abdominal, Cipro or Levo can be used along with metronidazole. For pneumonia, Levofloxacin or Moxifloxacin can be used. Ciprofloxacin dosage for pneumonia it is 400 mg IV Q8 hourly or oral dose 750 mg Q12 hourly. For other UTI and joint infection is 400 mg Q12 hourly or 500 mg Q12 hourly in case of oral dosages. Adjust according to the renal requirement. If there is GFR is less than 10, go for once daily dosing. Levofloxacin is a single dose, once daily dosing. For serious infection, reserve usage for only for the serious infections. And 750 mg per oral once daily. In case of low GFR less than 50, go for 70 mg once in 2 days. If GFR is less than 20, 70 mg once, then 500 mg once in 2 days. Moxifloxacin, the standard dose is 400 mg IV or oral once daily. So no renal adjustment is required. Avoid in hepatic dysfunction. So when severe hepatic dysfunction is there, avoid moxifloxacin. It is not the dosage is not affected by obesity also. So pharmacologically, levofloxacin is and moxifloxacin is 100% bioavailable, whereas ciprofloxacin 70% bioavailability. Excellent intracellular penetration, high levels in lung, prostate, kidney, bile, and reasonable CNS penetration is also there. Elimination, ciprofloxacin is 40% renal eliminated and half-life is around only 4 hours. Levofloxacin is 85% is renal elimination with half-life of 6 to 8 hours. Moxifloxacin is hepatic metabolism, half-life of 12 to 15 hours. It's a poor UTI drug, does not clear renally. So it does. Moxi alone has hepatic metabolism, other two has renal route of elimination. So one take-home slide that you need to understand is fluoroquinolones are very powerful drug but carry significant toxicity risks such as QT prolongation, CNS, and tendon. So always avoid whenever possible. Use it in only those scenarios that we have mentioned in this video. Stewardship, it is never the first line drug if alternative exists. Always assess QT risk, CNS risk, and tendon history for administrating a fluoroquinolone drug. So hope you have learned the significance of using a fluoroquinolone drug for the infections that you commonly encounter. So don't prescribe a fluoroquinolone, ciprofloxacin or ofloxacin or moxifloxacin for a acute gastroenteritis patient. Never do that because The patient already will have hypokalemia and may have hypomagnesemia with the ECG changes. When you give it, you can precipitate acute risk prolongation as well as ventilator tachycardia. So, hope you learned a lot in this video. If you like this video, do like and subscribe and share it with your friends. This is Medicine Beyond Harrison's. Let's meet in yet another video. Thank you for watching.